respected honorable dignitaries, friends and colleagues. I bring greetings from the Department of Surgical Oncology, and I stand here in great humility, humbleness and gratitude. This is the great banyan tree which was planted by Dr. Swarnkar, and you can see the small little surgical oncology department taking its roots. This tree is now being nurtured by Dr. Vikas, and I stand here in great humbleness and gratitude that we have grown, not grown in size, but in gratitude for the immense body we have been provided with, the infrastructure, ever-increasing infrastructure that is being provided to us. The minds which have developed this center and on whose shoulders we stand here today, the intellect which keeps us guiding constantly, and things from beyond. In great gratitude I stand here because they guide us and they are responsible for where we are today. This is our faculty. Each one is a sought-after surgeon with great accolades and achievements to their personal credit. These are our residents. In fact, these are our showcases. The first batch has already passed out and doing well in life. Second batch has just made us proud, and this is the rest of the team. This is a photograph with our children, the MCH. This is our extended family. We cannot exist without the pathology, the radiation oncology, medical oncology, plastic. You name the thing, every one we are depending upon. And this is our super, or you can call it superb extended family. We do not limit ourselves to one place, but we include everybody. This is the oncology department from SMS along with the Mahatma Gandhi team, and we play together, we work together, and we collaborate in many ways than one. If you come to our theater at any time, you will find that there is all the specialties available, and this is the golden part of this institute, that you have the neurosurgeon, the urologist, the anesthesiologist, the gynecologist, everywhere, everyone available to you and ready to help in any time. As far as the academic activity, we have about 111 publications, about 200 participation in conferences and seminars. We have an intensive academic program every Friday and Saturday, and a skill development program, which is a unique program which we have daily, where the residents make these things. They make diagrams, they make instruments, they discuss x-rays and everything. In fact, this book, the workbook, was so much liked by the last examiner that he has taken that book and he will follow this at the Adyar Cancer Center. Each faculty has cabinetfuls of awards and achievements. As far as the departmental statistics are concerned, we see approximately 4,000 new patients, about 14,000 old patients put together, about 18,000 patients in the OPD. We admit about 2,000 patients annually, and we operate about 1,600 major surgeries every year. This is our busy oncology OPD. The space is falling grossly short. These are the facilities, the wards, wonderful wards and places to be in, world-class operation theaters. Every case which is difficult is discussed in the multidisciplinary tumor board. We have tumor board 2 times a week, and about 20 cases are discussed every month, and we provide world-class treatment to every patient. We continuously have technology transfer programs, orations, faculty lectures. Anybody coming from abroad or having attended a conference, they come and enlighten us. We are constantly updating in operative skills. OncoSurge is a flagship program. Every year we have a live relay exclusively to Jaipur from Tata Memorial Hospital. It's a 3-day program. We also participate in the patient support groups and rehabilitation activities, public education, advocacy and awareness programs, educational grants and fellowships. Thank you to the management that they are providing a lot of fellowships and promoting people to publish and attend conferences and workshops. We also do team building and de-stressing programs, take them for yoga, meditation, take them for outings and make them comfortable. Also do professional education activities. We have our share of friction, problems and situations where we sit down and discuss, and thankful to the management that they provide us so much of facilities that we can sit together with the operation theatre people, the staff, and sort out problems. This is another good program we have, the Oncology Residents Orientation Program. We have a very tough residency program. So to make them comfortable, Dr. Vikas also participates in this, and they make them comfortable when they come in. I think कुछ ज़्यादा ही comfortable हो जाते हैं residents. We have interstate mock or DNB examination. We hold 2 to 3 mock examinations which are actively participated by faculty from all over the country and students from all over the country. This is the mock examination, some pictures from there. And after the mock examination, we have the final examination. In fact, it is not an examination of the residents, it's an examination of the faculty, the department and the institute. It is how you make the examiner feel. He takes back memories from the institution and says, yes, this department is doing really well. And these are the 2 examinations. And a special program we have after the examination, when the examiners sit together with the residents and discuss what are the pitfalls, what are the achievements, and what more can be done. Yes, we also do surgery. Surgery from top to bottom, head to toe, major surgeries which are done at very few places outside. All major surgeries including HIPEC, sentinel node biopsy and everything. And we are finally very thankful to Dr. Swankar and the management for having provided us the latest toy in our armamentarium, that is the Robo, and this is a dream come true. Really thankful, and I'm really grateful that I'm able to stand here in this institution, and it's really humbling to be in this institution. Thank you very much.
Good morning, honorary dignitaries, my senior faculty members and professors, my dear colleagues. I'm Dr. Prekshit from the Department of Surgical Oncology. We have a case today of a 50-year-old male who presented to us with dysphagia. Me, along with my peers, are going to be discussing this case in front of you. So, a 58-year married male from higher middle class working as a bank professional presented to us with difficulty in swallowing since 2 months. On history of presenting ailment, the patient was apparently asymptomatic 2 months ago. He then developed difficulty in swallowing, which was gradual in onset, progressive, initially to solid, then to semi-solids, but specifically not to liquids. The patient initially could eat 2 to 3 rotis, but then shifted to khichdi and dalia. It was accompanied with weight loss, which was not quantified, associated with a sense of food sticking in the upper chest, as evident by the patient requiring liquids to assist his eating habits. On negative history, there was no history of any recent onset fever, chest, abdominal pain, regurgitation, vomiting or altered bowel habits. There was no cough, dyspnea, retrosternal burning, jaundice, hematemesis or hemoptysis, and no bone or back pain. On past history, the patient was a hypertensive since 2 years, well controlled in medications. He was taking tablet amlodipine 5 milligrams once a day. There was no past history of any comorbidity, no previous surgical history, no history of similar complaints in the past. There was no history of corrosive ingestion or trauma, and no known allergy to any food or drugs. The patient also did not show any signs of high-risk sexual behavior. On personal history, the patient was a cigarette smoker, started around 24 years of age. He used to smoke about half pack a day, quit 8 years ago. Totally smoked for about 26 years, that amounts to 13 pack years. No history of alcohol consumption or tobacco chewing. He's a vegetarian by diet with normal bowel, bladder and sleep cycle. On family history, there was nothing significant. So to summarize the case on basis of history, we have a 58-year hypertensive male who was a reformed smoker, presented to us with progressive difficulty in swallowing for 2 months, with unquantified weight loss and no other contributory history. So at this juncture, I would like to put up a question to the audience, what comes to their mind when they hear a history like that. Can anybody come up with the most common differential? Anybody in the audience? General surgery residents? Malignancy. Why do you think it could be malignancy? One point favor in history. Okay. So we move forward to causes of dysphagia. So we have to first localize the cause of dysphagia, which can be supraesophageal or esophageal causes. Supraesophageal causes can be ENT related, could be neurological, while on the other hand, esophageal causes, which forms a major chunk, could be either primary relating to the problems in the esophagus per se, could be secondary due to any other systemic ailment, or could be inflammatory like pill, caustic, eosinophilic esophagitis, GARD. And the other chunk is the mechanical part of the obstruction, which could be either due to malignancy, peptic strictures, or rings or webs. So another important point we have to make sure in the history is the grading of dysphagia. Since a patient could concentric thickenings of the esophageal wall, commonly present either in the cervical esophagus or over at the lower end of the GE junctions.
Causes for those rings and webs?
So we have sideropenic dysphagia, Patterson-Kelly-Brown syndrome, which causes esophageal webs and rings.
What are the vascular causes of rings?
So we have arteria lusoria, which can also cause posterior compression and cause a ring. So on continuing with grading of dysphagia, we either the patient can have can be eating normally, or the patient can be will have difficulty in swallowing saliva as well. Our patient, because had difficulty in taking semi-solids, came in grade 3. So moving on to general physical examination, it was the patient was conscious, alert, oriented to time, place, and person. And general physical examination was grossly normal. On locoregional examination, the head and neck was examined first, which showed no significant abnormality. Part of locoregional examination also involved
palpation करो तो thyroid mention कर दिया करो, ठीक है ना?
जी sir. On continuing locoregional examination, the chest was also examined, which was within normal limits. As part of locoregional examination, the abdomen was also examined, which showed no abnormalities. And a rest of the systemic examination was also normal. So to summarize up till now, we have a 58 years hypertensive male who was a reformed smoker, presented to us with progressive difficulty in swallowing for 2 months with weight loss and no other contributory history, and grossly normal physical and clinical examination. So again, I would like to audience, how do we proceed from here? Is there any thoughts in your mind?
I think a couple of things need to be brought out. This patient presented with dysphagia.
Right, sir.
We've done his examination.
Yes, sir.
Now the cause of dysphagia, like you said, starts from top and goes to the stomach or down below. Now, I think the first thing you need to look at it is the post-cricoid region. We've missed out on the examination part of the throat. The post-cricoid region, the pooling of saliva in the piriform sinuses, the laryngeal crepitus, because that would give rise to a diagnosis for a piriform sinus malignancy or a post-cricoid malignancy. We need to rule those out in this age group definitely, especially if he's been a reformed smoker also. Smoker was there in the history of there in the past. Okay, fine, 8 years he has reformed himself. But this I think must be mentioned in any examination for dysphagia.
Right, sir. So we examined laryngeal crepitus, sir, which was normal.
Because that is something which is important. Post-cricoid area is evaluated only by that clinically, or the indirect laryngoscopic examination, where you could be able to see the piriform sinus pooling.
Point noted, sir. Thank you.
What is odynophagia and how will you differentiate from the dysphagia?
So odynophagia is generally painful deglutition. The patient complains of pain while deglutition. Dysphagia is, we define it as difficulty in deglutition. The patient either will have
Does it have any significance with respect to the etiology?
Yes, sir. Odynophagia could mostly localizes to oral cavity lesions like Ludwig's angina or probably
the anatomical side. What are the causes, whether it is neurological or vascular or pathological, mechanical? What does it signify?
So odynophagia generally signifies mechanical inflammatory pathology.
Inflammatory or even neurological?
Even neurological. Yeah. Thank you, sir. On probable diagnosis, again we have the same list. Since we had a normal general physical examination, most of these causes were ruled out. And in a patient with 58 years of age, history of smoking, the first differential that came to our mind was malignancy. So on initial, we requested for initial routine evaluation, which was essentially all normal. Next, we moved on to the first line investigation, which was an upper GI endoscopy. The upper GI, as evident in the pictures, we found an ulceroproliferative growth at 28 to 32 centimeters from incisors. The scope was negotiable beyond with resistance and multiple biopsies were taken. At this juncture, I would want to extend my gratitude to the gastroenterology colleagues and faculty members who are readily available for us at any point of the day for endoscopies and colonoscopies. So the biopsy, continuing with the case, the biopsy was suggestive of a squamous cell carcinoma, modifiedly differentiated grade 2. So this is how the inference of 28 to 32 centimeters is important for us as the treatment modality changes. So our lesion lies somewhere at the junction of the middle thoracic esophagus and lower thoracic esophagus. So next, after confirming a diagnosis, a staging workup was requested for. We planned for an FDG PET-CT in this patient. Now, I would like to call upon Dr. Chaitanya to discuss about the staging PET.
Thank you, Dr. Prekshit. Good morning, respected faculties and the dignitaries. So the patient was subjected to an 18F FDG PET scan. So these are the MIP images of the FDG PET scan, in which apart from the physiological uptake, we can see a focal tracer-avid lesion at the lower thoracic region. So these are the sagittal, axial and coronal image of the lesion, which shows FDG avid eccentric heterogeneously enhancing lesion along the left lateral wall of lower thoracic esophagus. Sorry, sir. With an SU max of 15.4, maximum thickness of 2 to 2.3 centimeters and an extent of 6.2 to 6.5 centimeters along the D6 and D9 vertebrae. In these axial images, we can see that the lesion is closely abutting the pericardium anteriorly without any obvious infiltration, and the angle of contact with the lower descending thoracic aorta was less than 90 degrees. Along with the lesion, there were few subcentimetric size low-grade FDG avid lymph nodes at the gastrohepatic and perigastric regions. So the inference of PET scan was long segmental lower thoracic esophageal wall thickening with few regional lymph nodes and no distant metastasis. Now I would like to call Dr. Prekshit for further management of the case.
Thank you, Dr. Chaitanya. So on summarizing the case, our final diagnosis was made. A 58-year gentleman, ECOG1, with carcinoma lower thoracic esophagus, squamous cell type, grade 2. This is the TNM classification that we generally use for all solid organ malignancies. So we staged the patient according to TNM as CT3, which shows invasion into adventitia as evident by the complete wall thickening, and N1 as regional nodes, and M0 as no distant metastasis were found. So the disease was locally advanced. Sorry. Next, since the case was discussed we discussed this case in the multidisciplinary tumor board meeting, and the tumor board decided, in view of the advanced nature of the disease and long segment thickening, neo-adjuvant chemoradiation to be given first, followed by response assessment and planning for radical surgery later on. The rationale was the locally advanced nature, and our intention was to treat with potential curative.
When you do upfront surgery without chemoradiation?
So, either a short segment, either a T1 lesion, we can go for surgery. T2 lesions, early T2, SM1 disease, we can go for upfront esophagectomies. Node negative disease.
So the patient was referred to the Department of Radiotherapy, and neo-adjuvant radiotherapy was planned along with concurrent chemotherapy. The dose for radiotherapy was 41.4 gray in 23 fractions at 1.8 gray per fraction for a duration of 4.5 weeks, and the radiation was delivered on 5 days of the week, Monday to Friday. The role of definitive chemoradiotherapy in esophageal cancers comes into picture when there is a disease in the cervical esophagus. The patient is medically unfit or surgical inoperability is there. So we go up to doses of 50.4 gray in 28 fractions for definitive chemoradiotherapy. Target delineation was done using the standard guidelines, which define the gross tumor volume as macroscopic disease on the CT slices. The clinical target volume for the primary disease includes gross tumor volume plus any microscopic disease which may not be visible on imaging, but it has at a high risk of subclinical disease. The margins were given craniocaudally 3 cm and a 1 cm radial margin was given, which was cropped from all uninvolved normal tissues. The clinical target volume for the node was given by generating a 0.5 cm margin in all directions to the grossly involved lymph nodes. These are the representative images where the red arrow shows the gross tumor volume, the orange contour shows the clinical tumor volume of the primary, and the and the blue line shows the planning target volume, which we'll be discussing in the further slide. The next image shows an axial section where the gross tumor volume for the node and the clinical target volume for the node are shown. This is a sagittal image showing all the three volumes: the gross tumor volume, the clinical target volume, and the planning target volume. The regional lymph nodes were also covered. These are the representative slides showing the regional nodal volumes which we had covered for the treatment. So the planning target volume, it includes clinical target volume with an additional 1 cm margin to account for potential uncertainties in patient positioning, organ motion, and setup variations. It ensures adequate dose delivery to the target area and minimizes dose to the surrounding normal structures, which are also known as organs at risk, which are the spinal cord, lungs, heart, liver, and kidneys. These are the normal tissue tolerances for the organs which are at risk during radiotherapy of the esophagus. A radiotherapy plan was generated for a rapid arc plan was generated, and respecting all the dose constraints, and the patient was also given concurrent chemotherapy. So for the concurrent chemotherapy part, I would like to invite my colleague Dr. Priyanka. Thank you.
Thank you, Dr. Vatsala. A very good morning to all the respected teachers and dignitaries present here today. Taking the case forward, after giving the written informed consent, the patient received 5 cycles of neo-adjuvant chemotherapy concurrently with radiotherapy, which included paclitaxel at the dose of 50 mg per meter square and carboplatin AUC2. The patient was monitored for CBC and other routine organ function tests prior to administering each cycle of chemotherapy, and was monitored for any chemotherapy related adverse effects on each visit. Patient tolerated the chemotherapy well, with the entire neo-adjuvant treatment well, with minimal toxicities. Thank you. To take the case forward, I would now like to request Dr. Prekshit.
Thank you, Dr. Priyanka. So after the neo-adjuvant treatment was completed with a total duration of 34 days, the patient was, during the treatment, the patient had weekly reviews in our department for nutritional assessment and chemoradiotherapy related adverse events. We also started the patient while during this period on prehabilitation, as we were going to plan for a radical surgery. The patient was, the nutritional support was taken care of, psycho-behavioral support was given, and the patient was also emphasized, the emphasis was laid on inspiratory muscle training. Clinically, the patient had near complete resolution of dysphagia. He started eating solid foods again. And then we planned for a radiological assessment 5 weeks post completion of chemoradiotherapy. For the response evaluation part, I would like to call Dr. Chaitanya from Nuclear Medicine Department.
Thank you, Dr. Prekshit. So the repeat PET scan was done of the patient after concurrent chemoradiotherapy for response evaluation. These are the MIP images of both the scan. We can see a reduction in extent and intensity of the lesion at the lower thoracic region. On the axial images, we see a reduction in FDG uptake and maximum thickness of the lesion. In the sagittal and coronal images, we can see the decrement in extent of the lesion. Along with that, we saw reduction in FDG uptake and SU max of the gastrohepatic lymph nodes and resolution of perigastric lymph nodes. I would like to call Dr. Prekshit.
Thank you, Dr. Chaitanya. So, on finally summarizing the case post neo-adjuvant therapy, we have a 58 years hypertensive male, ECOG 1, with squamous cell carcinoma of lower thoracic esophagus, status post neo-adjuvant chemoradiation, with a very good clinical, metabolic and radiological response. The case was rediscussed in multidisciplinary tumor board, and the patient was then planned for radical surgery. So now we have a lot of options for esophagectomy. So these are 3 types of open esophagectomies that we had. So the challenge was to choose a procedure right for the site of the disease and the type of the disease. The first one, as we can see, the first 2 images show transhiatal and the 3 incision approach. In both of them, we take a neck incision and we remove the esophagus and we make the anastomosis in the neck. The third one is the Ivor-Lewis approach, in which we do not open the neck, we remove the esophagus and we make an intrathoracic anastomosis. So this is also called, the transhiatal is also called the Oringer's approach, the 3 incision is called the McKeown's approach, and the Ivor-Lewis is called as the Lewis-Tanner approach. The pros and cons of these approaches, they're based on 2 important factors. First is the site of the anastomosis, and second thing, if we are dissecting around the chest or not. The first 2 procedures, the Oringer and the McKeown, since we make a cervical anastomosis and the stomach has to be pulled up, there is high chances of leak, but because it is in the neck, there is reduced morbidity to leak. But since and also the anastomosis is high up in the neck, so there is less chances of post-operative reflux. But since the 3 incision McKeown approach and Lewis-Tanner involve opening of the chest, there are more pulmonary and cardiovascular complications in these. So these 2 approaches, since we have a cervical anastomosis, will have lesser morbidity to leak, although more leak, but lesser morbidity to it. But these 2 approaches, since we open the thorax, will have more complications, and since we are opening the thorax, we'll have increased lymph nodal yield, which is important for surgical radical surgeries. Next, we also now have the minimal invasive esophagectomies, which can be done by 2 methods. First is the conventional thoraco-laparoscopic approaches, and the second is a robot-assisted approach. Also, a very crucial step for all radical surgeries in oncology is lymphadenectomy. And esophageal malignancies specifically need lymph nodes at the dissection at the neck, the chest and the abdomen. So we have 3 types of lymphadenectomies that we routinely practice. The first one is a standard 2-field. We can see the dissection done from the level of the carina till the abdominal lymph nodes. The second is an extended or modified 2-field lymphadenectomy, where we can see that the lymph node dissection is done from above the level of the carina and also the abdominal lymph nodes. And the third one is a 3-field lymphadenectomy, which involves the cervical lymph nodes as well. So we routinely do an extended 2-field lymphadenectomy. So after discussing the plan in management, we had options of either going with a classical open approach, a conventional thoracolapparoscopic, and now we are extremely grateful to our management that we have robot in the hospital, so we could offer the patient all the three approaches, and he was free to decide whatever approach that he could take. But the plan was to do, the patient agreed for a robot assisted minimally invasive esophagectomy. We planned for a Mechion, a 3-incision esophagectomy with a 2-field lymphadenectomy that we routinely do. So we again we did a pre-operative workup with routine biochemistry, nutritional assessment, PFT, 2D echo, a pre-anesthetic checkup. We counseled the patient well about the pros and cons of the procedure, and we took a written informed consent. On the day prior to surgery, the bowel was prepped. 2 units of PRBC were arranged, and the necessary arrangements for Da Vinci X robotic systems were made. Now I would like to call upon Dr. Medha Raina to discuss about the anesthesiology challenges.
Thank you, Dr. Prekshit. Good morning to all the senior. Good morning to all the dignitaries, senior faculty, and all fellow residents. I'm here to present the anesthetic challenges that we faced in this case of robotic esophagectomy. We did the pre-anesthetic evaluation of the patient, where the major concerns were the pulmonary function test, which was 70%, which is borderline, and the anticipated difficult airway, as the Mallampatti grade was 3. The anesthetic challenges were majorly one lung ventilation, positioning of the patient, limited access to the patient, which is not only a concern for this particular surgery but all robotic surgeries, and long duration of the surgery. Induction and intraoperative management. We induced the patient with standard rocuronium, propofol and fentanyl infusions. Adequate IV access was obtained via large bore peripheral cannulas. Right radial artery was cannulated for invasive BP monitoring, and depth of anesthesia was maintained with propofol infusions, which is target control infusions, dexmedetomidine infusion, and rocuronium infusion. For intraoperative and postoperative management of pain, a lumbar epidural catheter was introduced at L1, L2 space, and as we can see in this image, the positioning of the patient is a concern, so adequate strapping was done for safety purposes, gel padding was done to prevent injury at the pressure points, and axillary roll was also done to prevent any brachial plexus injury. Now we talk about the lung isolation and airway management, where the first plan was placement of a double lumen tube. The 39 French left-sided double lumen tube was inserted, and bougie guided insertion was done with the help of a video laryngoscope, and position was confirmed with a fiber optic bronchoscopy. The plan B was an EZ bronchial blocker, which was not required since our plan A was successful. At the end of the surgery, the one lung duration was approximately 3 hours. The total anesthesia duration was 7 hours, and the approximate blood loss was 250 ml. After thoracoscopic resection, the patient was shifted to dual lung ventilation, and since the duration of the surgery was prolonged and there were increased lactate levels at the end of the surgery on the ABG, so the patient was electively mechanically ventilated, but the patient was shifted to ICU and extubated the next day uneventfully. For post-operative pain management, we managed it with epidural top-ups and multimodal analgesia. Thank you. Now I'd like to hand over the mic to Dr. Prekshit.
Thank you, Dr. Medha. So the first step was to do a staging laparoscopy. The patient was in supine position, and we made the routine camera port and 2 additional ports for manipulation. We found a 1 by 1 centimeter surface nodule over segment 5 of the liver. We resected it out and sent for frozen section, which came out to be negative. I would again like to thank our oncopathology team. They are on their toes till 4 o'clock or even 5 o'clock. They help us out whenever needed, and they give us our reports on time. Like, I know we pester you guys, but thank you so much. So operating room setup. The first part of the robot was the patient cart. We placed it from the dorsocranial end of the patient. This is the vision cart, which is placed in front of the assisting surgeon. And then we have the surgeon console from which the surgeon operates. The assistant surgeon was sitting on the left hand side of the patient and the anesthetist on over the head end. So this was how the OT setup was made. Next, one thing that lays very important point with esophagectomy is the thoracic duct identification during the thoracic mobilization. So for that we had the intervention radiologist. Again, thank you for helping us out every time we've called you. They helped us with the ICG mapping. What they took 2 ml of 25 microgram ICG and they injected in the corticomedullary junction of bilateral inguinal nodes. We can see the inguinal node and the needle inserted in it. So the stage was set. The first phase was thoracic mobilization of the esophagus. And after, we shifted the patient into a semi-prone position and the standard robotic ports were made. After placing the robotic arms, the next step is to dock the robot. So this video shows you how we docked the robot to the ports made. We can see the system being shifted towards, the lasers being aligned with the port, and that is how the robotic arms get attached to the ports. After docking, we started with thoracic mobilization. So, disclaimer to the video, the video is going to be running on 2x speed and I'll be explaining it side by side. So we started the procedure with, first thing was to adhesiolize the adhesions to the lung and the chest wall. So you can see the great maneuverability and visibility the robotic system offers us. We can pick up every small flimsy tissue and we can dissect it out. So the dissection was divided into 2 parts, the suprazygous and the infrazygous. We started with the infrazygous part first. So we can see the posterior intercostal veins draining directly into the azygos. We can see the dropped right lung down there, and we can see the thoracic duct with the margin of the thoracic duct there. We start with the mobilization of the inferior pulmonary ligament, which is dissected from the inferior lobe of the right lung to mobilize the lung and find the medial margin of the esophagus. Again, I would like to comment how easily and nicely we can handle the lung without causing injury to it, and it provides us with such great maneuverability. Next, we started with the right pleural dissection. The medial margin of the esophagus was defined, and the pleura with the lung was dropped medially. After completing that, the next step was the para-aortic and mesoesophageal dissection. During this dissection, we make the lateral margin of the esophagus. We completely dissect out the adventitial tissue along with the lymph nodes of the paraesophageal region, and we drop it along the radical specimen that is going to be coming out. You can see the close proximity of the big vessel, the descending thoracic aorta, being safeguarded so easily with the maneuverability the robotic arms provide us. So the dissection was completed from cranial to the caudal end up to the hiatus at the diaphragm. The esophagus at the para-aortic mesoesophageal dissection and the right pleural dissection were completed up to the hiatus, safeguarding the thoracic duct, which we can visualize now. The ICG helped us identify the thoracic duct so easily. Next, after finishing this dissection, we completed the hiatal area where we can mobilize the lower end of the esophagus really well. After that, we moved cranially and posterior to the esophagus. We can see the pericardial dissection being carried on. The whitish structure was the pericardium. We lift the esophagus up, we make a window and we cross about, and we complete a circumferential dissection around the esophagus. So you can see we made a window and we're completing a circumferential dissection around the esophagus. So we lift up the esophagus and we go beyond it to free it up from the pericardium and the left pleura. This is the area where we find the right main bronchus, which is an important structure to be saved. So this was the dissection we carried around the right main bronchus. And the next part was to finish up the infrazygous dissection with the subcarinal lymph nodes and the AP window lymph nodes, which are important for a thoracic esophagectomy. we can see it was a piece of, I wouldn't want to say a piece of cake, but because the maneuverability is so great that the vision is so nice that it's so easy to dissect out important structures and safeguard them. After completing the infraazygos, we divide the azygos vein to go above the azygos. So we create a window, we pick up the tissue, we create a window, we go beyond the azygos vein and we clip it on the proximal and the distal end. We can very beautifully see the azygos vein getting dipped into the superior vena cava and the right lung being dropped down. After ligating the azygos vein, the next part was the supraazygos dissection, which again robotic surgery helps us doing this, as we have a recurrent laryngeal nerve lying right near the right paratracheal area. We can also safeguard the membranous trachea, which is a common site for injury. After completing the esophageal mobilization, we placed an ICD drainage tube at the bed. The reason why we laying emphasis on a robotic surgery is because it was a bloodless field. All the structures could be easily identified without causing any morbidity to the patient. So this was the view behind the scenes when the robot was working. After that, we go to the abdominal and the cervical phase. So that is a stomach tube we make and we pull it up to the cervical area and we complete the anastomosis in the neck, which finishes up our dissection. Lastly, when we made the anastomosis, ICG also helped us identify good vascularity in the anastomotic structure, which reduces our leak rates. We can see the greenish ICG picking up, showing very good vascularity at the anastomotic site. So this was the resected specimen. The first part on the cranial end, we can see the supraazygos esophagus along with the paratracheal lymph nodes. Then we had the subcarinal, the infraazygos esophagus, which has a good adventitia. The subcarinal nodes, mediastinal and paraesopharyngeal nodes dissected along with it. And then we have the fundus of the stomach and the abdominal nodes dissected along with it. So post-operatively, on post-operative day 1, we could extubate the patient, mobilize him and start his feeding jejunostomy. On post-operative day 5th, the left ICD was removed. On post-operative day 11, we removed the right ICD as well. We discharged the patient after conducting a gastrographin study, which we can see showing no cervical leak at all. Now I would like to call upon Dr. Kusha to discuss about the oncopathology part of it.
Thank you, Dr. Prekshit. Good morning, respected teachers, faculty members, colleagues and residents. I'll be discussing the histopathological aspect of this case. So we received a specimen of robotic assisted minimally invasive esophagectomy in our department. The tumor bed measured 4.5 into 1.5 into 0.5 centimeter. The tumor was situated in the lower 1/3 of the esophagus and it was 3 centimeter away from the gastroesophageal junction. We also received an intraoperative consultation for liver nodule for this case and it was negative for malignancy. So this is the gross image of the specimen and it shows, since this was a post-CTRT specimen, there was no obvious growth which was seen in the lower esophagus. However, there was an area of ulceration which was extensively sampled and routinely processed for microscopic examination. So the left-hand side image is showing the mucosa which is lined by stratified squamous epithelium as pointed by the blue arrow. The underlying submucosal tissue shows mild to moderate chronic inflammation. There were few submucosal glands which were showing squamous metaplastic changes. However, there was no dysplasia or invasive malignancy seen in this section. At places we could also see foreign body giant cell reaction to the keratin. This is a higher magnification of the same image which is showing clusters of multinucleated giant cells surrounding keratin flakes. So this finding is important as it suggests post-therapy changes. There might have been viable tumor cells in this area prior to therapy. This is the image of the lymph node which is showing reactive changes and all the lymph nodes dissected were negative for malignancy. So for all post-therapy surgically resected specimens, we employ a tumor regression score to ascertain the response to therapy, and for this we use the modified Ryan scheme for tumor regression. So in this scheme, if there are no viable cancer cells, then this denotes a complete response and it is given a score 0. So since in our case there were no residual viable cancer cells present, so a final impression of pathological complete response was given with a tumor regression score of 0. All the resected margins were free of tumor and there were 16 lymph nodes resected which were all free of tumor. So the final PTNM staging given was YPT0N0. Now I would like to request Dr. Prekshit to take the case further.
So coming on to the review of literature, the first literature that came out in favor of minimally invasive surgery with esophagus was the TIME trial. The TIME trial suggested a shade better disease-free survival, but significantly better overall survival with minimally invasive esophagectomies. So this was the landmark trial which established that minimally invasive surgeries can be done with esophagus. Then first trial that came, the first retrospective study that came, the latest retrospective study comparing robotic versus laparoscopic was that came all the way from China, suggested that they took about 577 patients, compared them to robot assisted versus conventional. They found reduced blood loss. They found a better lymph nodal yield with robot assisted techniques, and they also found there were significantly lower pneumonia and post-operative complications. The next was specifically a trial
Do we have Indian data also for that?
Not currently, sir.
Sir, but that is only for limited patients.
Limited. Next we have a trial specifically for squamous cell carcinomas, because these patients tend to receive radiation, and radiation makes surgery difficult. So that is why they had the subset of patients, which is the RAMI trial, which also shows improved thoracic nodal dissections with robotic surgeries. Now I would like to, summarizing my case, thank you, I would like to call upon Dinesh sir for discussing it further.
So good morning all dignitaries, sir, and my colleagues, my senior faculty members and students. So after completing this whole presentation by Prekshit, it's nothing to present by me, but still why we selected this patient for this CCR presentation. So thoracic oncology is relatively that branch which is not routinely taken up by different hospitals and other peoples, because there is anatomical structures, major blood vessels and neurological structures that come in our field. So majority of people avoid these type of surgeries. After availability of advanced instruments like we have a Stryker laparoscopic set that is having facility of ICG, and with invent of this robotic, we are going with further treatment of thoracic oncology patients. Now within last 6 months we have increased our cases of thoracic oncology cases, sir. So that is why we had chosen this patient for presentation in CCR. So this is our experience of esophagectomy patient as a whole, open, thoracolaparoscopic and robotic surgery patients. So total we had gone with over 100 patient esophageal surgery patients. Out of that 25 patients was inoperable due to metastasis or high nodal burden or high tumor burden, sir. 79 esophagectomy we had gone, and out of the 79, 16 were of thoracolaparoscopic and 4 were of robotic surgery. So what advantage we got with the robotic is, first thing, we all faculty members are available in OT. Nitin sir, Dr. Rahul, Dr. Sanjay, or Dr. Rahul Koopchandani, our new AP. So everybody is available in that field, so we are comfortable we can use robotic in a proper way. So in all these 79 patients, either open, thoracolaparoscopic or robotic, we are margin negative, sir. And average lymph node yield is improved by thoracolaparoscopic and even more with robotic surgery. So every surgery in the thoracic part comes with some complications, and the major complications in our open surgeries were 3, and minor were 5. Minor were routinely managed by opening the neck incision, because majority of patients we do MGUMST. So neck incision is there. So routinely it is managed by opening the neck and irrigation of that fluids. And major that are treated with IR department help or by intensive ICU care and other things, sir. So with minimally invasive, its in major complication was in only in 1 patient and minor was 2 patients. Till now, it's counted as 1 month mortality in these patients. That is perioperative mortality. We do not have any perioperative mortality in 79 cases. So you can have see benefit of robotic surgery and open surgery. So this one is open surgery case, sir. So in open surgery, it's approximately 25 or 30 centimeter incision, and patient have post-operative pneumonitis complications and other complications. On this side, you can see it's a small incision, so post-operative there is no any major pneumonitis and respiratory complications in these patients. So remaining is covered by Prekshit. So there is
अभी last क्या position है patient की follow?
Sir, this one. This one is.
What is the dysphagia cure, and can you show the
basically, sir, we have data
how
for
much
that.
clinically he is cured or sort of? What is the current status of the patient?
Sir, the current status of patient is, this patient is discharged yesterday, so we are presenting it. And even with the previous 3 patients, they are comfortable and no major complications. Only in 1 patient we had that complication, that is managed by IR department. Yes, sir, 1 single patient.